This is a great opportunity. We have had some really interesting conversations about radiation and immune therapy in different kind of nuanced contexts. We've had discussions about efficacy of checkpoint blockade in the context of immunosuppression with steroids or other immunomodulators. And we have discussions about lung cancer and GU bladder malignancies, as well as patient-facing issues of lifestyle choices, microbiota with Jen McQuade. So a good opportunity if you have some questions from the morning that we haven't had a chance to kind of discuss yet. Go ahead, Omar. Yeah, I appreciate your participation today.
It's all fun. This is where we live this stuff every day. So I've been doing all these immunotherapies going way back. As a matter of fact, I did a fellowship here with Alan Houghton back in immunology in 1986 to 7. So that, but only in the last month, I've had 2 patients, one stage 3, one stage 4, who went into fluoride DKA from nowhere, just acute bang DKA. And so we got through that. The stage 4 they're both, the stage 3 one's adjuvant. The stage 4 one is having a glorious response, brain, lung, liver. And then both of them, not only were they treated at the same time, which makes me wonder what kind of nivolumab was I giving those 2 patients that day. But then right on schedule, I resumed treatment, and they both ended up in the hospital last week with hypopituitarism, both of them. It's like they're following a similar trend. One's female, she's the adjuvant, she's a nurse, and the other one is a really big guy, and they're both around their 56 or so age. But the question I have, and I appreciate that because we hit this question just a few days ago, I like the notion you made, which is that you don't have to use immunosuppressive doses when you hit that adrenal insufficiency or the hypopituitarism. You just need to give them replacement doses, and that might be a better move. The question is, for the stage 4, it makes sense for me to continue to drive, okay, because it's me or we're in trouble. The adjuvant patient, I'm wondering if I'm pushing my luck. Now, she's already done hypothyroid before I met her. She went into DKA, and now we just put her into fluoride hypopit, and she's going to show up in clinic next week. And she otherwise looks great because the steroids help. And we just moved her into replacement dose rather than blasting her. The question is, would you continue to treat the lady?
Maybe I'll jump in on this because melanoma is one of the spaces where adjuvant therapy is widely used. And I think you've touched on, I don't think there's, I'll fast forward and say I'm not sure there's one right answer here, but you've touched on 2 aspects of managing toxicity that I think it's important to highlight. One is for these endocrine issues, especially for our stage 4 patients where the stakes are so high, we've typically viewed things like hypothyroidism or adrenal insufficiency or even DKA as unfortunate consequences of toxicity, but things that can be managed with supplemental and supportive management, and therefore not a reason to discontinue. Sometimes I've told my patients with stage 4 disease, well, we know you won't get this side effect again because we presume we permanently damaged this, and it's unlikely we'll be able to fix it, but we can manage and continue. And for my stage 4 patients who have endocrine issues, I almost uniformly would continue therapy if there was an indication to continue therapy. For my stage 3 patients getting adjuvant treatment, I will say the risk-benefit ratio in my mind is a little bit different, and I have been quicker to discontinue adjuvant therapy when there are multiple toxicities. In this particular case, I suppose if we follow the reasoning that you're unlikely to recover endocrine function, it wouldn't be so much because of the toxicities that she already has, which you're likely stuck with, but the toxicities that she might have. And I think you could also provide some reassurance that in clinical trials, of adjuvant treatment, likely she would have been discontinued for toxicity. And so the data really is completing a year of treatment was not the collective experience for all of the patients randomized for adjuvant treatment. Of course, some discontinue treatment early for toxicity, and she likely would have fallen into that category.
Wonderful. I appreciate that. The funny thing is she looks so good, and maybe the way to rephrase the question is, if we do continue, and this would be a question for the audience, and everybody in here's got experiences. So we've already hit 3. She already pre-did the thyroid. She did DKA. We just messed up her pituitary, and she's coming out fine. Let's say we did continue the therapy because it's manageable. What have people seen? Has there been, what would be the next toxicity that would scare you in her?
I'll be happy.
So are we talking about the adjuvant patient?
Yeah.
Well, yes. So Maggie's answer was much nicer than what I would have answered.
Wanting to treat her again?
So if we go back to the data, for the adjuvant data, we talk about this a lot. There's no evidence that we're improving survival in these patients yet. There may be data coming up, but so now you have a patient who may already be cured from her surgery, and we're picking off her endocrine system one by one, and we're giving her permanent side effects. For me, I would stop right now. If you believe that there's a benefit to adjuvant nivolumab, there certainly is no data that says you have to give more drug than you've already given. You've already activated T cells or whatever you've activated to result in the loss of her pituitary function. I think she's had enough. That's what I would do. I would stop.
Well, since I'm more of an induction or neoadjuvant kind of guy, I am in your camp, but I was just begging the question of what would be next from a side effect that she can conjure up after doing it.
Yeah, I don't think there's a playbook that
unclear.
allows
There's no
us
playbook
to
around there.
say 1, 2, 3, this is going to be 4. And
Okay.
if anyone knows of it, I'd be happy to.
And
Borrow that playbook.
I think for non-small cell lung cancer, that's really the additional field and disease that we're seeing the use of adjuvant, or we call it consolidation, checkpoint inhibitors in that setting for patients who've received chemotherapy and radiation and go on to receive a year of adjuvant consolidation, whatever you want to call it, durvalumab. And I think our clinical experience is the challenge of what do you do with a patient who may be well served by their chemotherapy and radiation already, who doesn't have progressive disease, who we don't know how much effect the durvalumab is really doing, but we certainly know that it could be causing toxicities, and teasing out those troubles along the way is challenging in discussion of patients, which is worth pushing through and which is worth stopping treatment. And I would say collectively as a group, it's been challenging to get people through that year of therapy, not because they've progressed through disease, but things pop up along the way that we don't know if it's really related to toxicities of chemotherapy and radiation or immunotherapy and other things. Things are not kind of classic, a cough, inflammation, things like that.
I also think it's really important with my informed consent. I am very explicit about permanent endocrinopathies and type 1 diabetes. I think, again, they get glossed over a little bit because we can supplement, but these are, especially in the adjuvant setting, young patients, right? Those are the patients that you want to give the most benefit for. But again, these permanent endocrinopathies can really change the course of their entire lives.
Yeah, I agree. I have a separate, standout discussions saying while they might not be as serious or life-threatening, although they can rarely be, they're permanent, and so it's worth pausing and specifically considering that.
And to try to bring in the radiation discussion, in head and neck radiotherapy where maybe the thyroid may or may not be covered, is there any kind of worsening of toxicity with local treatment modality as it may relate to some of these endocrinopathies? Is that known?
In combination with immune checkpoint
Pembro
blockade?
or whatever.
The trials that have looked at combinations of chemoradiation with immune checkpoint blockade, they've reported only early toxicity data, and hypothyroidism tends to be a near-term or late toxicity. Just with CRT alone, probably 30% of patients will develop hypothyroidism. So, but I in the randomized trials that we presented, both of which the majority of patients had lung lesions irradiated, we didn't see any increase in the rate of pneumonitis. So because we didn't see any increase in the rate of pneumonitis with checkpoint blockade combined with radiation to a lung lesion, I don't expect to see an increase in hypothyroidism beyond an additive increase. I don't think we're going to see some sort of synergistic increase in the head and neck patients.
I would just say I don't know in my own personal experience and from the existing data, I don't know that there's an increased risk if you develop an endocrinopathy that you will develop other immune-related toxicities. I haven't had that experience in my own patients that have developed endocrinopathies, and I don't know of any existing data. I think, but I still agree, with Paul and with Maggie for your adjuvant patient, probably worth seriously considering stopping. But for the metastatic patients, again, as Casey said, a lot of it's a question of timing. I just had a patient that developed type 1 diabetes as well on therapy. He's further out. His metastatic disease is further out from his initiation of treatment. And so then it becomes a question that I think dovetails nicely into our next discussions of how long do we continue these treatments to begin with.
And we do have a session this afternoon on endocrinologic complications of immune therapy, so I think we have an opportunity to discuss this in much more detail then after lunch. So we have just another minute or two if others have questions. Just a quick one then before we go, and I'm starting to get a little hungry too myself. Jen, how do you do a controlled feeding study? It sounded like 3 months of controlled feeding for patients on immune therapy.
So
how do you actually do that?
So we have a dietitian / chef who prepares all of their meals, and twice a week it's either they pick it up or it's couriered or shipped to them. And it's all of their food already partially prepared, and then other things that they then get the kind of instructions to put it together. But yeah, we're literally providing them all of their meals. It sounds great, right? All patients want to do it, but it's also, it's really isolating. I'm not providing meals for the rest of their family, right? I'm not
It's not like a Blue Apron.
No, it's not a Blue Apron, right? Or, if you want to go out to dinner on a Saturday night with your friends. So we look for, the standard for controlled feeding studies is looking for 70 to 80% adherence. So they're allowed cheats occasionally, but then they basically, they get their menu and they have to then write down what percentage of everything that they ate, note if they did anything additional, and so it's all clearly, the adherence is clearly documented.
Well, it's really great work and very interesting. Unless there are other questions, then we will go to our first break, and we'll come back at 10:45, and we have 2 more talks right at 10:45 about head and neck squamous cell cancer and efficacy of immune checkpoint blockade in colon cancer, and then we have 2 more debates about how long to treat patients with immune therapy, and then questions about adjuvant and neoadjuvant therapy prior to lunch. Thank you guys for your attention.